Okay, I don't know what happened there. I put it on record and slideshow, and now we got a blank screen. So let's try it again. Okay, everybody can see it now?
Yes.
Yes.
Okay, and we should
Yes.
be recording. Okay. So first, we're just going to cover a little bit of cardiac. We'll do a couple questions, and then we'll try to get into chapter 10 a little bit. All right, so you already know that the heart is a double pump and it has two circulation systems, one of them being systemic, one of them being pulmonary. So it's pumping some of that blood through the lungs and some of it throughout the body. The main things that you need to know is where that flow is and where those valves are, because that is going to dictate what happens in the heart. All right, so everything's coming in through that inferior vena cava from the body, and that is coming in there needs to be oxygenated because it's already been used by the body. All the nutrients are out, all the oxygenation's out. All right, so it's going to come in from that inferior vena cava into the right atrium through the tricuspid valve into the right ventricle and into that pulmonic valve and out to the lungs. Okay, so any problem with the pulmonic valve, look at where it is. Okay, any problem with the tricuspid valve is going to cause a problem with the right side of the heart. And those two things could be right-sided heart failure. We're talking about what's broken in the heart, not symptoms. When it comes to symptoms, you're going to see something different. But when it comes to right-sided heart failure, the main causes are going to be either an MI, tricuspid valve stenosis or regurgitation, or that pulmonic valve stenosis. And the reason being because the blood now has to go through those valves. And if it's stenosed, it's going to have to push harder. It's going to have to work harder, the right side of that heart. And because it has to work harder, that is going to lead to possible right-sided heart failure. All right, so after that blood leaves the lungs, now it's fully oxygenated. It's got the nutrients it needs to get back out to the body. So it's going to come into the left atrium, go into that bicuspid or mitral valve, into the left ventricle, and then out the aortic valve to the aorta and out to the body. So now the valves you have to worry about on the left side of the heart for left-sided heart failure are going to be the aortic valve and that mitral or that bicuspid valve. Okay, if either one of those are stenosed or damaged, that's going to cause the left side of the heart to work harder. What else affects left-sided heart failure?
Hyperthyroidism.
Okay, I was thinking more
CHF.
hypertension, because when the left side of the heart is trying to push the fluid out to the body, is going to meet more resistance in high blood pressure. Okay, so as it's trying to push out, it's hitting that extra resistance, and that also can cause left-sided heart failure as well as an MI on the left side. Part of the issue is when these parts of the heart are working harder, your ventricles can develop hypertrophy because that muscle is having to work harder now, and that's going to cause the ventricle to get thicker. Less blood can now go in that ventricle because of that. So how does that flow work again? You have the deoxygenated blood from the inferior vena cava through the tricuspid into the right atrium, through the tricuspid valve, into the right ventricle, into the pulmonic valve, out to the lungs. At the lungs, tissue exchange takes place. Now you have that oxygenated blood coming back through the pulmonary vein into the left atrium, through the bicuspid or mitral valve, into the left ventricle, the aortic valve, out to the aorta, and out to the body. So your blood is flowing into the lungs from the right side of the heart. If you throw a clot, it's likely going to end up in those lungs. Same thing if you throw a clot in the left side of the heart, okay? Right side, it's going to throw the clot into the lungs more than likely. Left side, it would throw a clot into the aorta, which could either go to the brain, to the carotids, or somewhere out to the body. Your circulation system, that includes the heart, the blood vessels, the blood. Remember that heart is a pump, okay? It's a big bad pump. If something happens to that pump, it's going to affect the whole body. Now, last week we already learned how it's going to affect certain things like the kidneys, right? Because if the heart's not pumping, the kidneys aren't going to get enough fluid. And that's going to cause the kidneys to release renin and try to bring that pressure up. We talked about all that. You should have a good understanding of that. What else could be affected here? The lungs. Okay. If the lungs aren't getting the fluid flowing through, or they could back up because the heart's not pumping, or because there's a problem with the pulmonic valve. So that's when you're going to see those signs of congestion in the lungs. Okay. The heart can back up and affect the body. So left side of the heart is going to affect the lungs. And that's where you're going to see congestion, short of breath, difficulty breathing. The right side is going to affect the body, and so you're going to see a backup in the legs, in the liver area, in the abdomen. That's where the fluid's going to back up. The blood goes through the body through three vessels: arteries, veins, and capillaries. Arteries are carrying oxygenated blood. Veins are bringing the deoxygenated blood back. And at the capillaries is where all that exchange is taking place. Okay, so that heart is going to help with circulating those nutrients. It helps with immunity. It helps removing carbon dioxide. It does a lot of things. Common conditions that could happen with the heart are high blood pressure. Okay, you could just have normal high blood pressure where it's a little over the normal, which we'd want to be what, like 120 over 80. But now maybe your blood pressure is 135 over 85. Okay, it's a little elevated. What happens when it starts to go up more? So what happens when now your blood pressure's let's say 180 over 120? So what's happening in the body because of those high blood pressures? That's what you want to think about. So now you're at risk for things like a stroke. You can damage those vessels. You can damage your eyes. Anything that has small vessels. And MI. This is where you have a blockage in those coronary arteries. The most common cause is that broken off atheroma. It's just piece of plaque. So plaque, blood, all that stuff can stick to those arteries because over time the arteries become weak, they become stiff, and partially is because of diet. All right. So what kind of diet are you eating? Remember that lard, okay, or that fat that you have in a pan. Let's say you're cooking chicken, even if it's just vegetable oil. Let's say you're cooking chicken and when you get done, you leave the vegetable oil in the pan. What happens to it? It goes from a liquid to a solid. Okay. It does the same thing in your arteries. Goes from a liquid to a solid. Now, your arteries typically are soft and pliable, but now that this plaque starts accumulating on there, and if you have diabetes, this can contribute to it because the sugar breaks down the vessels. Okay, so all these things are contributing to damage to these vessels. And that puts the client at risk for an MI because anything could break off there and clog the main coronary arteries. When those become clogged or blocked, then we develop ischemia there. Why do we have to do a bypass? Because if the tissue is necrotic, you can't use it. Once it's black, necrotic, it ain't coming back. So now you got to get a bypass. Still a vessel from the leg, still a vessel from somewhere in the body, and go around that area of necrosis. Heart failure, this is when the heart can't pump. And typically it's because of the causes we just named. So, what are those conditions that I said are going to cause left sided heart failure?
High blood pressure.
Okay, high blood pressure is one.
MI.
An MI in the left side, that's two. What else? Two more.
Aortic valve stenosis.
Okay, aortic valve stenosis, good. What else? What other valves
Artery.
there? What other valve is on that left side
Oh,
of the
the
heart?
mitral valve.
Okay, the mitral valve. And what about the right side?
Pulmonary
The
valve stenosis.
tricuspid.
Okay, pulmonary valve, tricuspid. What else?
You said regurgitation, right, Ms. Loach?
Yes, right-sided MI. Any condition that makes that right side pump harder. So regurgitation could be an issue there too. Most of the time with regurgitation, we worry about things like strokes because with regurgitation, what are you going to see building up there? Because you have static blood sitting there. So we got to worry about blood clots, okay? But anything that makes the heart work harder on that side can contribute, okay? Most of the time with these conditions, they'll probably talk about stenosis, but I do want to make you aware any problem with that valve, even if it's incompetent, can make the heart work harder, and that could lead to it. Other conditions that we'll see is arrhythmias, okay? So you have to know that SA node is that main pacemaker, okay? When that SA node is conducting that signal, it's going down through the AV nodes and it's going to stop there for a minute. Why?
Gotta wait for it
It
to
has to
fill
fill
up.
up.
Okay, it's got to fill up. Okay, and then it's going to move on down the bundle of his. Okay, the Purkinje fibers, and then it'll perfuse and contract. Okay, so there's some arrhythmias like AFib. Okay, AFib is usually less than 350. Okay, I mean A flutter is usually less than 350. So look at your book and what are those numbers for A flutter? A fib is usually going to be 350 or more. And then some other things you could see here is a heart block. So like a first degree heart block is
Wait, Miss
when,
Lowe,
yes,
you said a fib is less than 350 or more
a
than?
fib is going to be more than 350. A flutter is going to be less.
Okay.
A fib is more of a concern than a flutter, really. Both of them happen a lot in the elderly. The AFib is going to be the higher of the two. Okay. All right. The other one I was going to talk about was the heart blocks. Okay. So when you think about it, it's a delay in conduction, a heart block. Okay. So with the first degree heart block, like your wife's supposed to be coming home, she's running a little bit late. Eventually she comes home. With the second one, she's supposed to come home. Maybe she decided to stay overnight. So now is a little bit later coming home. And with the third one, she ain't coming back. Okay, so that's how the heart degree works. First, you have a little bit of conduction issue, then it's a little bit longer of a delay, and then the signal's not getting there at all in third degree block. So that's what I'm talking about is the signal, okay? That's your wife. Your wife is that signal or your husband. All right. Then you know that arteries, the main things about circulation there. This is all chapter 10 too, because these go together. Arteries are carrying blood away from the heart, veins are carrying blood to the heart. The capillaries are going to be those little vessels where the gas exchange can take place because they're real thin, really, really thin. All right, we were just talking about this, the conduction pathway, okay, that SA node, that AV node, the AV bundle, the Purkinje fibers, that's how that conduction is running. Some things that we'll see that we already talked about, atherosclerosis, they like to ask about this, okay? So you should know like what's modifiable, what's not modifiable. Atheroma is that buildup of plaque that breaks away and blocks the artery. That's that plaque that breaks off and goes into the vessel and goes towards the heart and blocks it. Bradycardia, tachycardia, what's the difference between those? Okay. Tachycardia, your rate's going to be over your normal. So normal, your book should probably say 60 to 100. For bradycardia, anything under 60. Who would normally have bradycardia?
Athletes.
Athletes.
And some of your older adults. And anybody on beta blockers. Okay, what do the waves in EKG represent? So P wave is depolarization of the atria. The QRS is depolarization of the ventricles, but also in that QRS, you can't see it, but you have repolarization of the atria as well. And then the T wave, which represents that resting phase. So it's repolarization of the ventricles that happens right before it starts all over again. Okay. And all this stuff on the right, we just talked about. So you guys know that already. Cardiac control center in the medulla oblongata is going to control the rate and the force of contraction. That's in your brain. Okay. And then baroreceptors in your carotid arteries and your aorta are the first to detect those changes in blood pressure. So they're going to eventually stimulate what? Let's say your blood pressure's low. What would they stimulate?
Renin.
Running out.
Renin.
Angiotensin.
And then renin would stimulate
Angiotensin.
angiotensinogen 2. Angiotensinogen 2 is going to stimulate
Aldosterone.
aldosterone and eventually
88.
ADH. And together, these things will bring up the pressure. Sympathetic nervous stimulation. This can bring up your heart rate. Parasympathetic is going to decrease your heart rate. So sometimes if someone's having certain types of SVT, we might tell them, hey, cough or bear down, because that could stimulate the vagal nerve and slow the heart rate down. If I didn't have any medication to give somebody, this might be a way I could do a nursing intervention if I don't have something. You should be aware of things that increase the heart rate. So anything that causes vasoconstriction, and most of these do, right? Increase in the thyroid hormone or epinephrine. So thyroid hormone is going to increase your metabolism. Epinephrine is going to speed things up. A body temperature will increase your metabolism. Environmental temperature will increase your metabolism. Exercise will increase your metabolism. Smoking, vasoconstriction. Stress response will stimulate sympathetic nervous system, epinephrine, and lead to vasoconstriction in certain parts of the body. Pregnancy. With pregnancy, usually your heart rate increases because now it's you and the baby. Also, as the baby gets a little bit bigger, it'll displace the heart a little bit. And then pain can increase, but mostly acute pain. Usually people with chronic pain, we don't see changes in their vital signs. You should know what cardiac output is, and that is the amount of blood ejected from the ventricle in 1 minute. So it's equal to your stroke volume times your heart rate. Stroke volume is the amount of blood going out of that ventricle. Preload, it's what's coming back to the heart, okay? So if you're laying down at night and blood is coming back to the heart, going in that right atrium. That's your preload. Now, if that preload is too much, what's it going to cause the heart to do?
Expand.
Stretch. The heart will stretch. When it stretches, what happens? Because it's got too much fluid. Who's responsible for that now?
The ANP.
NP.
The AMP. So the AMP is going to do what? Tell the kidneys to do what?
To close the gate.
Stop observing.
Stop producing renin. Okay, stop producing renin and inhibit aldosterone and ADH because we have too much fluid coming back into the heart. So that should be the normal process. Okay. Afterload is how much is required to push the blood out of the ventricles. If that's too high, it's going to increase the peripheral resistance. That is where we get the high blood pressure. That is going to be damaging to the left side of the heart because that big bad pump now has to work way harder to push that blood out into that aorta and out to the body. All right. This is just showing you the different waves here again and what they represent. Anybody have any questions on anything that we talked about so far, cardiac? All right, your hematologic system. This is helping bring oxygen, nutrients, hormones, waste products throughout the body. The red blood cells carry the oxygen using that hemoglobin, and white blood cells are your army. They're going to help you fight the infection. Platelets help everything stick together. We need that blood to clot sometimes. So we need it to stick together when it's supposed to. Plasma. This is like a water type of substance that's in the blood. It contains water, proteins, and nutrients, as well as hormones and wastes. And then common conditions that we might see here are anemia, leukemia, hemophilia, thrombocytopenia, sickle cell. Okay, so anemia is a low red blood cell count, and there's a couple different kinds. So you have iron deficiency. Who do we mostly see that in?
The older people?
You will, but our big population is who?
Dialysis patient?
Toddlers and teenagers. Why? If it's iron deficiency, why?
Good diet.
They're growing fast and they're picky eaters, okay? So those two things can contribute to this. We also have a couple types of hemolytic anemias. What are those?
Sickle.
Sickle cell and thalassemia, okay? And so how do those affect the body?
Sickle cell is the shaped one, right?
Like not getting enough oxygen into the blood cells.
Okay, because the cells are dying early, they're being killed. And when they're being reproduced, a lot of times they're immature. Because the body, that process of apoptosis is being bypassed there. The cells are being destroyed for both of these. They're being lysed or broken down. And the lysing of those cells causes what to produce in the body? What happens when red blood cells are broken down? What's produced? That's harmful to the body. Bilirubin, yes. Okay. Leukemia. This is an infection, a cancer. Okay. It's a cancer of the white blood cells. Hemophilia, there's two different types. They're due to clotting factor disorders. So you have hemophilia A, which is clotting factor 8, and hemophilia 9, clotting factor 9, which is your Christmas disease, or hemophilia B. Thrombocytopenia, where we don't have enough platelets, and that can put us at risk for bleeding. And then sickle cell, where we have those abnormally shaped red blood cells that cause blockages and pain. All right, you should know the difference between your arteries and your veins. Okay, the arteries and the veins are both made of 3 layers. The arteries are going to be more elastic, okay, because they have to be able to expand. So you can understand that when the arteries are damaged with plaque, they don't have that ability to expand anymore. And that's going to affect the way that they work in the body. They also have to be able to recoil. That helps them maintain blood pressure. The veins are going to have thinner walls than the artery. They have less smooth muscle. That vasoconstriction and vasodilation in those arterioles is controlled by autoregulation. So whenever there's some kind of change, like a decrease in our pH or an increase in the carbon dioxide, that can cause the vessels to change shape so that the body can accommodate that issue. Also, releases of things like histamine in the body can cause vasodilation. Now, typically, when do we see histamine released? Whenever there's some sort of inflammatory response in the body. All right, your red blood cells, those are helping. Those are originated from the kidneys. They're going to be released in response to any sort of hypoxia or whenever we don't have enough oxygen. So, in someone that has something like COPD or sickle cell, they can have really viscous blood from the body trying to constantly reproduce these in response to that hypoxia that they're feeling. If the kidneys aren't working, then your body's not going to be able to produce this erythropoietin. So when people that have poor kidney function, will give injections of this. For your red blood cells to work right, okay, you need the right amount of amino acids, iron, B12, B6, and folic acid. Now, B12 deficiency is pernicious anemia, and that could be from an autoimmune disorder, from gastritis. Here we have a lack of production of hydrochloric acid in the body, usually, sometimes none or little to none. And so the body's not able to break down that intrinsic factor and use it, and they're not able to absorb that vitamin B12 there. So they'll have a beefy red tongue, they'll have neurological problems with their legs. Iron deficiency anemia, we talked about. You can have this from a lack of folic acid. Okay, folic acid. People should take a certain amount every day. All these things have to do with how your nerves function. People that have problems with B6, B12, folic acid usually experience some sort of peripheral neuropathy. And with iron, we're looking at other issues in the body. And then, in addition to that, they're going to have shortness of breath, fatigue. The body's going to break down the hemoglobin after it's used. So usually it'll break it down. Okay. The iron gets recycled back into the system. The hemoglobin is going to be broken down into heme and globin. The globin will be used for amino acids. This is the normal process. Okay. But in sickle cell, it's breaking down too fast. And in thalassemia, it's breaking down too fast. And that's causing it to produce excessive amounts of bilirubin. So these people will present with jaundice. Normally, this is a process that we would want to happen. The liver, if everything's working right, could keep up with it, remove the bile that's toxic, and store it in the gallbladder for use. Here, when the bile is not conjugated, then it can go into the brain and cause brain damage. Vitamin K is needed, okay? Vitamin K is going to help with blood clotting. So these are produced in the liver. So your liver has to be working for that. Also, calcium. You got to have enough calcium in your body. Okay. Your kidneys help control the calcium. Your parathyroid gland controls some of that calcium. Other things that help with clotting would be like applying pressure, using vasoconstriction. So, what happens when we have an injury? So, the first response is vasoconstriction. That can slow down the blood flow. And if it's a small injury, a platelet can form there. In larger vessels, the blood clotting mechanism in the body will have to kick in, and that would happen through a series of reactions. Plasmin eventually will form there once the site is healed, and that will break the clot back down. So you have this injury to the blood vessel. The blood vessels around it are going to constrict and reduce the flow to the area. The platelets will be activated there to stick to the site. They'll become sticky, clumped together, form this platelet plug, and then they'll kind of wall off the area. All right. And then fibrin will come there and act like a mesh to stop the bleeding. Blood typing. Okay. Blood typing is based on the antigen that's presented on the outside of the cell. So remember, if you have the A antigen, you have type A. If you have the B antigen, you have type B. If you have both, you have type AB. Okay. If you don't have either, then you have type O. The RH. If you're RH positive, you're going to have the antigen D on the outside of the cell. If you don't, then you're RH negative. The only problem would be when mom is negative and she has a positive baby. Let me make sure I'm saying that right.
I think that's true.
Yeah, I think you're saying it right.
Anyway, mom's baby blood and the baby's can't mix. It won't matter on the first baby, but it will happen on the rest. Okay. So mom will have to get something called Rogam to prevent her and the baby's blood from having a reaction if it's mixed in the future. Okay, so it happens when most of the time when mom is RH negative and the baby is RH positive. And then mom's antibodies on the second baby will attack the baby's blood cells and cause the reaction. What'll happen is the blood cells will start to lyse and break down. Okay, and that could eventually kill the baby if we don't take care of it. Other things could be a transfusion reaction. So if you gave somebody the wrong blood, they would have a reaction like a feeling of warmth in the involved vein, headache, fever, chills. So, protocols require that we stay with the patient for a certain amount of time whenever we are giving blood. Other things that could happen here. There was one other thing I wanted to talk about. We already talked about the sickle cell. We already talked about the universal recipients and universal donors. Okay. So who's what? Universal donor is O. Universal recipient is AB.
It was a test question. So with group O, they can also receive O blood as well, right?
Yes.
I'm sorry, they can only receive O, but they can donate it to A and B, right?
Correct.
All right.
So look here, group O, okay? They can only receive O. They can donate to A, B. So that's why they're universal donors, because they can donate to anybody. Your universal recipients are going to be your AB, because look at who they can take blood from. Everybody. And by the way, any of these pictures on here, you guys are welcome to take pictures of. I don't care. This isn't when I get to the questions, no, but as long as we're doing just a review, yes. All right, so O negative is a universal donor, meaning it can be safely given to most other blood types and a low risk of reaction. AB positive are universal recipients. They can be given almost any type of blood safely. So they can receive almost any type of blood, where O negative can give blood to almost anybody. Erythroblastosis fetalis, so that was the one I was just talking about, can happen if mom has Rh negative and baby has Rh positive. Anemias, these signs and symptoms you should know. So what causes the fatigue?
Lack of
Lack of
oxygen.
oxygen.
Okay, because that's what anemia is. We don't have enough oxygen because of the lack of hemoglobin. All right. What causes the pallor? The pale face. It's also that lack of hemoglobin, because remember, heme is what gives blood its red color, right? So typically when we're perfusing well, our skin is a little pink or a little bit red. Shortness of breath is going to be contributed to that oxygen. Tachycardia is going to be contributed to the amount of oxygen not being able to support the demands of the body. So that's going to cause the heart to work harder and faster because it's trying to get more oxygen out. I would know severe anemia, chest pain, only severe, okay? Otherwise, we'll see your normal things like shortness of breath, fatigue. They may have sores in their mouth, changes with their fingernails, changes with their hair. All right, so iron impedes, lack of iron impedes the synthesis of the hemoglobin. So because we don't have enough iron there, we don't have enough hemoglobin. And that reduces the amount of oxygen. So that is going to contribute to the shortness of breath. That causes that microcytic or that small cell hypochromic. So the cells are smaller and they don't have much color. There's also less stored iron. So the causes for iron deficiency anemia are going to be dietary intake, blood loss, chronic blood loss. And who mostly do we see with the dietary issues?
Babies and adults and kids.
Teenagers.
Teenagers and little kids, toddlers usually, because those are the ones that eat the worst and are growing the fastest. Sometimes you're older adult because they have to pick and choose between what they can eat or what they can take medication wise. So maybe they can't afford their food and their medication, so they have to choose. So almost all your anemias are going to cause similar symptoms, okay? Tired, weakness, pallor, cold hands, cold feet, shortness of breath. With pernicious anemia, you'll also see like a red beefy tongue. This is a little bit different because this is caused by malabsorption of B12. They don't have enough intrinsic factor. All right, so they have atrophy of the mucosa. The parietal cells aren't producing that hydrochloric acid. So their body is not able to absorb the B12 there. And a lot of times this is going to come with gastritis or autoimmune. Because they don't have the B12, that causes problems with conduction of the nerves. The peripheral nerves especially causes loss of the myelin sheath. And these clients end up with neuropathy that could be irreversible. That's for pernicious anemia. For iron deficiency, for pernicious anemia, we're still back to that. The most common cause is going to be malabsorption, okay, because they're not absorbing the vitamin B12. Not because they're not taking it in or eating it. Because a lot of times they'll try to increase it by giving them pills, but that's not going to work because they don't have the things that they need in the stomach in order to absorb the B12. So that's why we have to give it sub-Q. That's the only way for them to absorb it. Or IM. Autoimmune reaction in an adult or an older adult, chronic gastritis, alcoholism, destruction of the gastric mucosa. So that destruction comes from the alcoholism and other things. So B12 malabsorption, okay, is the main cause. And again, they don't have that intrinsic factor because they lack hydrochloric acid. Aplastic anemia. This is when the bone marrow is not working here. So pancytopenia is a decrease in all of the red blood cells, the white blood cells, and the platelets. Usually we'll see this with chemo, but there's some autoimmune disorders that can cause it. It's called aplastic anemia. Usually it's going to be a slow onset, okay? Because it affects the entire bone marrow, then we'll see problems with everything. So anemia from the red blood cell, leukopenia leading to infections from the white blood cell, and thrombocytopenia with things like petechiae and bleeding issues from the platelets. It can be permanent. It can be unknown what the cause is, but autoimmune disorders like systemic lupus erythematosus or exposure to certain toxins can cause this. Viruses like Hep C can cause this. Now, your iron deficiency anemia, that is going to be a microcytic or a small anemia. Your pernicious anemia, that's a magoblastic. That's a large blood cell anemia because we're dealing with immature blood cells here. So those are another difference between the two of them. Hemolytic anemias, these come from excessive destruction of the red blood cells or lysis of those red blood cells. So the two common things that we see this with are what?
Sickle cell and thalassemia.
Sickle cell and thalassemia. And then erythroblastosis, you can see it when mom has Rh negative, baby has Rh positive. With sickle cell, this is considered autosomal recessive. So what does that mean?
The body's a taking itself.
The what?
The
Is it
body
only
is a
one
taking
parent?
itself.
Isn't
No.
that with the
Not one
gene?
parent.
From
Yeah,
both
yeah, yeah.
parents.
Autosomal recessive is with the genes. So what does it
Okay.
mean?
Parents have to be a
From
carrier.
parents.
Both parents have to carry it.
Both parents have to give you one bad gene. Okay. A parent could give you one good gene and one bad gene, and would you have the disease?
No, you'd be
No,
a carrier.
no,
Okay,
career.
even if both your parents have it, there's not a guarantee you're going to get it. If both your parents have it, though, there's more of a likelihood of them either making you a carrier or giving you the disease. Okay. Depends on what genes they give you. So if they give you one good and one bad gene, then you're going to be a carrier. If they give you two bad genes, you're going to have the disease. If they give you two good genes, you won't have either. You won't be a carrier and you won't have the disease. Did you guys see those questions I put on the end of that slide for you? Did anybody go back and get the updated slide I sent you from
No.
yesterday? I put some questions on the end of it. And I added those slides on for the inheritance stuff to make it more understandable for you. So I would suggest you go back and take a look at it. You should have the Google link and it should be open for you. All right, so this is inherited. All right. And you get it from your parents. But you could have a mutation. Okay. You can have a mutation for any one of these diseases. All right. So what are you going to see in sickle cell? Again, it's going to be damage to those red blood cells. So you're going to have pain related to the ischemia, pallor, weakness, tachycardia, jaundice because of the lysis of those cells, splenomegaly because you're going to have extra red blood cells being broken down. So all these other things, congestive heart failure, all this has contributed to the occlusions there, the infarctions, the thickness of the red blood cells, the lack of the hemoglobin, the lysis, everything that you're seeing. If you think about those things that are happening in the body, it should clue you into what symptoms you're going to see. Again, if you don't have enough oxygen, how are you going to feel? What's going to happen in the body? Because if you don't have enough oxygen, your tissue doesn't have enough oxygen either. So what's happening when they're not getting enough oxygen? Polycythemia, this could be primary or secondary. This is when you're producing excessive amounts of red blood cells. In primary, okay, it's neoplastic disorder, and usually it's contributed to low erythropoietin levels. With secondary, it's usually due to some sort of compensation measure in the body in response to prolonged hypoxia, like in COPD, sickle cell. On the left, it's talking about thalassemia there. Okay. In thalassemia, we have a genetic defect where we have interference with the globulin chains. All right. And so that causes damage to the red blood cells because the ones that are missing aren't there and other ones come in that do damage to the chains. And that causes the hemolysis and the anemia. Again, because of the anemia, because of the breakdown of those red blood cells, we're going to have problems with enlarged spleen, enlarged liver. These places both are reservoirs for blood. So whenever the blood or the red blood cells or the products of that are breaking down, this is where they're going to go to. And then the hyperbilirubinemia is in response to the lysis of those red blood cells. Too much bilirubin being produced here. The liver is not able to break it down. The red blood cells are breaking down much quicker than they're supposed to. Blood clotting disorders we can have here. Okay, so this can be in response to either the liver not working, the vitamin K, sometimes different chemos, different radiation can cause a problem here because they can cause us to develop that aplastic anemia where none of the blood cells are working right. Also, thrombocytopenia here. Calcium is required here. So thrombocytopenia would be the platelets. And then calcium could be the kidneys, the parathyroid gland. Hemophilia A. So a couple things you should know about this, right? Mostly this is going to be boys. Okay, women are usually carriers. So you need to know that for the chapters we just did. And then this is a clotting disorder. They lack clotting factor 8. So here they won't bleed more than other people when they're injured, but sometimes it's hard to stop the bleeding. And they can bleed into the joints. This can happen after any sort of trauma. Von Willebrand's. Again, this is a type of inherited clotting disorder. This is caused by the lack of the von Willebrand factor, and that is a clotting factor that helps the platelets stick together here. So one of the things that we'll see here is that red face, okay, which is called plethora. All right, but we'll also see rashes, nosebleeds, bruising, hypertrophied heart because you have that thicker blood there. All right, DIC. This usually happens in things like sepsis. It can happen with birth. And again, usually because of a septic infection. Disseminated intravascular coagulation. So this is when we have excessive bleeding and clotting. The hallmark is activation of both coagulation and fibrinolysis, meaning that the blood clots are being broken down and produced at the same time, and the body ends up running out of clotting factors. So these people will start bleeding out of every hole in their body. IVs, the vagina, the rectum, the mouth, the nose. A lot of things can cause this, any sort of toxin in the blood, damage to the cells, burns, crush injuries. Myelodysplastic syndrome. Okay, this is where the blood cells aren't working properly. The stem cells stay immature and develop abnormally. And this can lead to things like blood cells that don't work correctly. So it's going to cause things like anemia, bleeding. Acute leukemias, these are characterized by a large amount of immature, non-functional cells in the bone marrow. Chronic leukemia is going to be more of those mature blood cells, but they have a slower onset. So usually ALL we'll see more in kids. chronic leukemias we see more in adults. With leukemia, we'll have usually the first symptom is going to be infection that we're trying to treat and it's not responding. And that's because the white blood cells aren't working correctly. Sometimes we'll see swollen lymph nodes depending on what type of leukemia it is and how quick it comes on. All right, let me see what else we got here for slides because I want to do some questions with you guys. The only other thing really that I didn't cover here is these aneurysms, okay? These are typically caused by some sort of trauma, some sort of weakening of the vessel. It can lead to things like syphilis and other syphilis and other infections can cause this weakening of the vessel or the tear in there. High blood pressure can cause this. High blood sugars all the time. So anything that's going to cause trauma to the inside of that artery can cause a problem here. And eventually the artery, because it's been weakened or because blood's leaking through the layers, it causes the artery to tear. And so the rupture occurs with the aortic aneurysm. And now that's a problem. With these, sometimes you can hear a bruit. Sometimes you can feel a pulse in the abdomen. Sometimes you can just see it there too, if you look right above the belly button. Rupture can cause moderate bleeding and severe hemorrhage and death with these. So typically they won't operate them till they get about to about 0.5. All right, if they're a 4, a lot of times they won't operate on them.